Students, today's topic is tests that look at hemostasis, which is the fancy way to say clotting or the stopping of bleeding. What I'd like you to do is have your week 3 notes that you've kind of reviewed. That would be helpful. And as promised, I start each lecture with a review from the previous week's content. So let me put this up and give you a second to read it. And so we have a girl that's about a year and a half old. She was admitted for varicella, and varicella is the fancy name some of you know for chickenpox. Disseminated is a term that we'll use later in the lecture, and disseminated means scattered or diffuse. So she has a fairly severe case of the chickenpox. Pancytopenia, if you have had medical terminology, use that medical terminology to break that word down. So we've had penia before. We had leukopenia or erythrocytopenia, which we said the more common name that's used instead of that one is anemia. So we have a decrease in cells, and pan refers to all lines or the total. And so we have a decrease in the blood lines that come from the bone marrow. Do you remember last lecture? And I hope I put in time to put these together, so I hope you're putting in time to watch them. Pancytopenia is a term that means all 3 blood lines that come from the bone marrow are decreased. Do you remember those blood lines that come from the bone marrow? We had white blood cells, which are present in the 5 to 10,000 range in adults. We had platelets, which we'll talk about today. They're present in the 100,000s. And then we had the red blood cells we talked about last week that are present in the millions. So if you had a factory that put out 3 different products, it puts out white blood cells that are present 5 to 10,000 at a time. It puts out platelets that are present 100,000. And it puts out red blood cells that are present in the millions in our blood system. If I shut that factory down, if something happens, a severe enough infection happens, that it shuts those blood lines down, which one do you think you'd see the shortage in that product of soonest? Well, it's going to be the one that's present in lowest amounts to start with. So what do you think would happen to this little girl who's critically ill now just because of the chickenpox? That's why we encourage people to get chickenpox vaccine. Her white blood cells would start to fall, then her platelets would start to fall, and eventually her red blood cells would start to fall. It's that it would take longer to see it there because we had millions to start with. She then has respiratory distress, and that makes sense because if you don't have as many red blood cells as you should, you're not getting the oxygen to the cells that you might need. She is acutely ill. She has evidence of infection in the form of fever. Let's use that medical terminology again, megaly, so we have an enlargement. Hepato, remember that refers to the liver. Spleno refers to her spleen, so her liver and her spleen are enlarged. And she has oral candidiasis, and that's the fancy way to say she has thrush. Those of you that have been moms or have been around children, you know that thrush is a yeast infection in the mouth. Any patient could get it. You could get it at any age, and what it represents is that the bacteria in the mouth have gotten out of balance. If I was really obsessive about hygiene and I used mouthwash excessively, I could get oral candidiasis, a yeast infection in my mouth, because I've lost that balance of healthy bacteria that needs to be there to keep this yeast in check. So in other words, the yeast have been able to kind of take off in this kid because her immune system is busy fighting these chickenpox. The body, the bone marrow, has been overwhelmed by this infection. There are types of organisms like viruses that could release toxins that would destroy things like red blood cells and white blood cells. So she's got a yeast infection. Her liver and spleen would be large. The spleen is responsible for kind of breaking down and removing those old red blood cells. Well, if we have a lot of blood cells dying, that spleen is working overtime. And the liver is really a big filter for the blood. So it's doing its job in filtering things, but it's getting full, and they can actually go into liver failure or kidney failure because of all the debris that's in the blood system. They've done some lab values. So because we had pancytopenia, I already knew I'm going to see less red blood cells than I should. So here's my hemoglobin. To remember that red blood cells, if they're decreased, your hemoglobin's going to be decreased and your hematocrit's going to be decreased. Your hematocrit should be like 40 to 55 of your blood should be solids. And hematocrit looks at the ratio of solids to liquids. So a normal hematocrit would be up around the 40 to 55 range. A normal hemoglobin for this little girl, it should at least be 12 to 14. So her hemoglobin's low. Her white blood cell count is low. It should be 5 to 10,000. It's only 1,300. She has, in her differential, she has a low seg count. And the bad news is, if your segs are low and you're fighting an infection, we'd love to see a whole bunch of bands. And we don't see that on this little girl. That makes sense, though, because with that overwhelming infection, her bone marrow's not capable of producing those new soldiers, so to speak. It looks like she has lots of lymphocytes, but don't fall into the trap of saying this is real significant. We don't have a whole lot of blood cells to start with. So we're concerned about the increase in lymphocytes, you bet. And usually that happens with a viral infection, and do you remember she has chickenpox, which is a viral infection. Her body's being overwhelmed, so it's not producing the right amount of segs, or just neutrophils, and it's not producing those new immature neutrophils, the bands. She does have a normal monocyte, but here's some of those metamyelocytes, and metamyelocytes were those little premature bands. So her bone marrow, it shows that it's capable of working, it just can't keep up with the demand. And her platelets should be present in the 100,000s, and it's only present in the 2,000 range. This term right here, ANC, is something that we see in a patient's chart sometime in the doctor's notations. It means absolute neutrophil count. So that physician has looked at the percentage of segs or neutrophils. They've looked at the bands, the amount that are bands. So the 7 plus 3 plus these little immature neutrophils. And they said, if we take 7 plus 3 plus 1, we end up with 11. They've done 11% of 1,300 and come up with an absolute neutrophil count. The actual number of cells that are neutrophils is 192 cells, which is very, very low. And even though we say neutrophils primarily help with bacterial infections, they help with all infections. So this little kid is very critically ill just with something simple like chickenpox. Okay, class 3, what's our topic? We're going to be looking at these things. We're going to look at some tests that evaluate a patient's ability to stop bleeding. We're going to look at some tests that involve blood typing and cross-matching, and I bet most of you have heard those terms. If you watch medical shows, you've heard those terms. We'll look at a test called Coombs testing, and we have direct Coombs and indirect Coombs. We'll look at a few of the blood products that are used for transfusion and where we get them, and just a real quick mention of the complications that could happen when you have a blood transfusion. So what does hemostasis mean? Well, it's the fancy way to say stop bleeding. And there are 3 things that happen when you have damage to a blood vessel. So I want you to think of a time when you've punctured yourself or you cut yourself with a knife. Initially, you have that bleeding that starts to occur, and if you take the time to look at it, usually we put pressure on it real quick, but if you were to take the time to look at it, you'd notice that there is a little bit of whiteness that occurs around that area as these muscles tighten down to try and keep there from being the ability for blood cells to sneak out. So there would be a little bit of a blood vessel spasm, or that vessel gets smaller. Then platelets come in, and the fancy name for platelets, or the medical name for platelets, is thrombocytes. Thrombocytes then would form a plug. As they form the platelet plug, then things like fibrinogen and fibrin come in to form and strengthen that platelet plug and form a more stable clot. So there were 3 steps in stopping bleeding. One is the blood vessel kind of constricts. That's a temporary thing. Platelets would be attracted to the site. They would stick to the edges of that blood vessel and form a platelet plug. And then to form a more solid plug, There would be fibrinogen, which breaks down into fibrin, and that fibrin forms a strong plug as it forms with those platelets. So this is a cool slide with those electron microscopes so we can get really cool pictures. I want you to think you know what these are because of their color and their shape. They're present in the millions in our blood. If you look at these things, there's quite a few of those. So we have lots of red blood cells. We have a few white blood cells. So what do you think these yellow things are? Those are what platelets look like. And if you look at the shape of them, kind of with those little grabbing edges, it looks like they could join together to form a plug. When we look at the clotting cascade, I'm not going to have you memorize this slide, and all it does is help sort out some of the tests we're going to do. When we look at the ability to stop bleeding, we could measure clotting factors. So clotting factors are done with Roman numerals. You've probably heard of hemophilia, and hemophilia affects usually factor 8. Clotting factor 8 is the most common type of hemophilia. There's a problem with you having too little of that. So to stop bleeding, I need clotting factors, I need thrombin, I need factor 1, and blood type factor 1 is actually called fibrinogen. Do you remember in the previous slide it said fibrinogen is going to break down to form fibrin, and that would join with the platelets and make a more stable clot. So as you look at the slide, the takeaway information is to stop bleeding, I need prothrombin, thrombin, fibrinogen, that degrades to fibrin. I need clotting factors, and there are 3 pieces to this clotting cascade. There's an intrinsic piece, look at all the steps in it. There's a shortcut, the extrinsic system. And when I get to this point, that is the 3rd stage. Now, this is not tying back to this one tightens down the blood vessel or anything. This is, of the clotting process, there are 3 parts. Intrinsic part, and it's going to focus on things like the clotting factors. The intrinsic system also includes things like thrombin. The extrinsic system is a shorter system, and like the name implies, there is a thing that triggers the clotting process, and in this case it comes from the outside. Something happened outside the blood vessel, like trauma, that would release that initial signal to start this clotting process. The extrinsic system is much shorter. It's from here to here. The intrinsic system, much longer. When we get to the 3rd stage of the clotting cascade, both processes end up in this one. We have thrombin, which acts on fibrinogen to break it into fibrin strands, which helps form that stable clot. So if I were going to test a patient, and I have a blood test that tests the extrinsic system, it's going to concentrate on thrombin being present for that level to be normal. It's going to concentrate on factor 8 being present to make that level normal. If I don't have enough factor 8 or I don't have enough thrombin, that's going to mean that it takes longer for me to stop bleeding. So I need these things to have my bleeding times within a normal range. And this intrinsic and extrinsic will become important as we move to further slides. Here's just a quick review. We have red blood cells present in the millions. We have white blood cells present in the 100,000s, and you can bet these little blue things are platelets. And these little straight lines are designated CF. What do you think that would stand for? So we have clotting factor. We have an injury that's occurred to a blood vessel. If it occurs on the outside of the blood vessel, like trauma, we don't know what caused this one. It looks like it's coming from the outside, so that would be, it would trigger the extrinsic pathway, the shorter one. If we have it come from the inside, it would be the intrinsic pathway, but both of those are going to result in platelets kind of accumulating, fibrinogen being acted on to break down to fibrin and to form that more stable clot. So some things that could affect your ability to stop bleeding. In other words, these are things that could make your blood more likely to bleed. And we talk about blood being thick or thin, and that's really not a good term. People say I'm on a blood thinner medication. We looked at the thing that affects how thick or thin your blood is, and it's hydration, and it's the amount of solids compared to the amount of liquids. That was hematocrit. If I had a high hematocrit, I have a lot of solids and not much liquid, so my blood is kind of thick. When we talk about clotting factors and hemostasis, we talk about the blood being slippery. If the blood is slippery, the platelets don't stick together very much, so what do you think would happen to your bleeding times? They would get longer. So what things will help me determine if my bleeding times are in the normal range? I need liver function, because guess what produces those clotting factors? The liver does. Guess what produces factor 1? That one that was really important in both processes, the intrinsic and extrinsic. The fibrinogen comes from the liver. So I need a liver that could work. If you have liver disease, if you're an alcoholic and you have cirrhosis of your liver, you can also have problems with your blood being too slippery and not clotting like it should. So let's say I'm an alcoholic and I fall and hit my head, and I start to have bleeding into my head. It's less likely that it would clot as it normally should. So maybe I die of a cerebral hemorrhage. We've already seen on the pictures how we need platelets to form that initial plug. We have intrinsic components of the clotting process. We have extrinsic components of the clotting process. And those extrinsic ones focused on things like vitamin K. That's part of this extrinsic process. Liver function is part of the extrinsic process. And we have things like drugs that can affect it. There are medications which make the blood slipperier. Heparin, warfarin, Coumadin. There's Hirudin. This is one that was based on leeches. So they looked at what does a leech have that when it bites onto a person, it can allow it to suck in that blood without it clotting, without a clot occurring. And they found that those leeches actually produce this substance that we can manufacture in a lab to give to someone. ASA is the medical way that we show aspirin. So aspirin can make your blood slipperier and less likely to clot. Low molecular weight heparins. In medicine, we like to shorten things to their initials, so it's LMWH. Low molecular weight heparins, like ones that we would see fairly commonly in the hospital, would be Lovenox. We see some Dalteparin around here. Fragmin is these are brand names, Lovenox and Fragmin, and enoxaparin is the brand name. Excuse me, the generic name. There are other medications that can make your blood less likely to clot or more likely to clot. If you're inactive or immobile, what do you think that would do? Would it make your blood more likely to clot or less likely to clot? So you're not moving around very much. Well, if you remember anatomy and physiology, it says that we have little valves in our veins that pump blood around when we walk. So if I'm not moving, they found that not only do those little things not move blood around like they should, my blood actually becomes more likely to clot for other reasons associated with the inactivity or immobility. But we think about that. What if we have patients who are paralyzed and they can't move or they're critically ill? So we've started recently, if you're a patient who's critically ill, who does not already have bleeding issues, like you haven't had a whole lot of trauma, we want to give you a medication that will make it less likely for you to clot because you're inactive or immobile. So we give you low molecular weight heparins. The low molecular weight heparins are associated with less risk and need less monitoring than medications like heparin, warfarin, Coumadin. However, those low molecular weight heparins are expensive. Those medications are given to you in shot form in your belly, and they typically cost maybe up to $600 to $900 an injection, and you would have to have those every day. Most patients for 2 to 4 weeks or longer. So it can be extremely expensive. Herbal supplements like ginseng and echinacea that people take to prevent a cold, they can make your blood less likely to clot. Vitamin K containing foods, and we've got vitamin K up here also. Vitamin K affects the clotting process. And in fact, if my bleeding time gets too long, one of the things they could give me is vitamin K. So vitamin K makes my blood less likely to clot. And vitamin K containing foods are things like green vegetables, your broccolis, your spinach. So if a patient's on a medication that makes their blood less likely to clot and they eat a lot of broccoli, it affects their bleeding times, the test that we do to evaluate the amount of medication they're on. So then we change their amount of medication and they quit eating as much broccoli. So that's something, these are things we talk to the patients about who are on medications that make their blood more likely to clot, or excuse me, more likely not to clot, because all of these things could affect it. We know that alcohol, all by itself, regardless of what it does to the liver, alcohol makes blood less likely to clot. Hemophilia is a condition where we have a lower ability to clot. Tissue plasminogen activator. So let's go back to that and see what plasminogen did. And I guess I don't have it in this picture. Well, we're not going to worry about it then. But that tissue plasminogen activator is something that actually dissolves a clot. So clots are forming in your body right now. Even if you're totally healthy, your body forms a few blood clots. The thing that helps us is our lungs act as a filter for that. And maybe you've heard of someone who's had a pulmonary embolus. Well, that was the lungs doing what they were supposed to do. But if it becomes big enough that it kills you, or large enough that we notice symptoms associated with it, then we probably have a problem with excessive clot formation. Our bodies are forming clots, and this TPA, tissue plasminogen activator, can dissolve clots. We give this medically to people. So what is it called if you have a blood clot in your heart vessel? A blood vessel that feeds your heart. Well, you're having a myocardial infarction, a heart attack. One of the medications we can give you is TPA. If it's caused by a clot, that clot should be broken down by this medication that we give to you in your vein. If you're having a type of stroke that's caused by a blood clot, then we could give you TPA in your vein, and it will go to that area and break down that clot. If you have an IV in that was really hard to get started, or it's in a really important location, and sometimes those intravenous catheters can clot, we can inject a little bit of TPA in there to try and see if we can dissolve that clot and save that IV site so that we don't have to poke you again. Okay, protein C. There's a thing called activated protein C. It increases levels and reduced production of thrombin. So it causes decreased production of thrombin, and it makes it more likely for you to bleed. Protein C, or activated protein C, is a medication or a type of medication that we would give to patients who are critically ill with sepsis, an infection in their bloodstream. So most of these things made my blood less likely to clot. There were a couple, like the only one we really talked about much was vitamin K containing foods, and vitamin K are things that would make my blood more likely to clot. Inactivity and immobility, more likely to clot. With the rest of them, my blood was more likely not to clot, so I would have increased bleeding. So how do we evaluate whether you have normal bleeding times? Well, we do some tests. One, we could just measure how many platelets you have. We saw at the beginning of this lecture how important platelets are in the process. They were the second thing that happens. Vasoconstriction, platelets are activated and attracted to the spot. If I don't have enough platelets, I'm not going to have normal bleeding times. They're going to be too long. A bleeding time. Can you imagine I just poke you with a lancet, a little device that would puncture your skin? And I wouldn't choose that based on I like you or I don't like you. I would have to do it with a device that's going to make a specific size and depth of cut so that I could trigger that bleeding. And the name bleeding time is just like it sounds. We're going to just watch this and see how long it stops for you to stop bleeding. Partial thromboplastin time and activated partial thromboplastin time. These are essentially the same thing. Prothrombin time, we shorten it to its initials again. I said we love to do that in medicine. And the difference between these two is PT is going to be a test that looks at basically the function of the extrinsic pathway of coagulation. APTT and PTT function on the intrinsic pathway of coagulation. So if I had a problem with vitamin K, and I have too low of vitamin K or too high of vitamin K, I'm probably going to see that in my PT test. If I have too high of a level of vitamin K, my prothrombin times are going to be shorter than they should be. I'm going to stop bleeding sooner than I should. So to do these tests, to do this one, we take a sample of your blood from an IV, or we puncture a vein and we get it. For this one, we poke you like it shows in the picture. For the PTT and APTT and PT times, we go ahead and take a sample of blood from your vein. Okay, here's what it might look like on a lab report. So we have a platelet count, and we can see what the normal value should be. It should be present in the 100,000s. This is kind of introduce you to those. If you've poked yourself, you've essentially kind of done your own bleeding time, a little less scientific, but you know, if you just have a minor cut, you don't have to do anything to it, and within at least 3 to 7 minutes, it's going to stop bleeding on its own. If I were on a medication that increases my bleeding times, my times would be much longer. If I don't have enough platelets, what do you think would happen to my times? So if I don't have platelets, I'm not going to stop bleeding as soon as I should, so my times would be longer. Prothrombin time. Here's that one that focuses on the extrinsic pathway. Here's the one that focuses on the intrinsic pathway. And here is one that looks and measures fibrinogen directly. So let's look at the piece that make up clotting. We need clotting factors. Well, we can measure some clotting factors like factor 8. We could measure those. Or we could measure fibrinogen to see, since it was one of the end steps of both the intrinsic and extrinsic pathway, is your body making fibrinogen like it should? Does your body have platelets like it should? Does your blood clot within a normal period of time? So if my PT and my PTT times are too short, does that mean my blood is clotting quicker? In other words, it's clotting more, I'm more likely to clot, or I'm more likely to bleed to death. If my PT and PT times are short, less than 10 seconds, less than 25 seconds, that means I'm more likely to form clots. If we have you on a medication to make your blood not clot as quickly, we'd expect that your PT and your PTT times are longer than the normal. That means it takes longer for you to stop bleeding. You have less of an ability to stop bleeding, and sometimes we want that to happen. Fibrin degradation products. So FDP, or we could do a D-dimer. This is two different tests. They've done FDP and they've done D-dimer. When you have clots that are breaking down, they release these substances. So these things tell us, just like this name sounds like it, when you degrade something, you break it down or you tear it down. Fibrin is the clot. We're tearing down the clots. Your body's forming clots. It eventually wants to tear down those clots so your body can heal and repair. So if someone has high levels of these, that means they're forming clots, because the only way to have these high is it means clots are breaking down. So the presence of increased fibrin degradation products means there are clots being broken down. If I have D-dimer that's present in higher amounts, it means that there are clots forming. There must be, because these things are end products of the breakdown of clots. All right, so let's look at it in a real patient then. So if you look here, here's your D-dimer. D-dimer level should be here. This person has a low D-dimer. So that would be a good thing if we were looking at a person who maybe has Oh, no, 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 no. No, I don't want to do that. Oh. Let's hope I can get back. No, I don't want to stop. Oh, that would be horrible. So, D-dimer, if the numbers are low, it means that the person is not producing amounts of things that are released when there's clots forming. So if we're saying, gosh, I hope this person isn't forming clots, it would be a good thing to see a low D-dimer. Increased D-dimer means clots are forming and then being broken down. Here we go to our PT time. It's within its normal range of seconds. Here we go, pro time. The pro time is, it's within its normal range, and the PTT is within its normal range. And I want to introduce you to another thing called INR. And let me tie all of these pieces together with a story. My dad had a problem called atrial fibrillation. It means that his atria are not emptying completely. They're not beating as well as they should, so they don't empty very well. And he's at risk for forming blood clots in his atria. If he forms blood clots in his atria, if they're on the right side of his body, then they could form pulmonary emboli. If they're on the left side of his body, on the left atrium, that means blood that's going out to the body into the head, so he could have a stroke. Because of that, his doctor started him on Coumadin. The other name for Coumadin is warfarin. And an interesting piece about those, if you've ever killed mice by giving them decon or rat poison, you are essentially feeding them Coumadin or warfarin. So you hear patients who say, I'm taking rat poison. They're telling you that they take a drug that makes them less likely to clot. They wanted that in my dad's case because they didn't want him to have a clot and then have a stroke. So by putting him on warfarin or Coumadin, Coumadin is a brand name and warfarin is the generic name, they made his blood slippery so that it wouldn't clot. Now there's a risk because if he takes too much of that medication, he could start to bleed to death. He could have excessive bleeding because he doesn't have an ability to stop bleeding very well. So when they put him on that medication, it's important that they, especially those first few days, monitor your bleeding times to make sure that they don't get the number too high. It's important that they kind of monitor and tell patients they have to kind of watch how much broccoli and spinach and things like that they're eating. It doesn't mean they can't eat them, but they should kind of eat them in constant amounts, the same amount each week or the same amount each month. So my dad called and he said, they started me on this new medication. I said, what is it? He said, it's, and he spelled it out, or he tried to pronounce it, and I could tell it was warfarin or Coumadin, and that made sense with his diagnosis. So in patients who've had a heart attack, we want to make them less likely to have another heart attack. And if that heart attack was due to a clot, let's make their blood thinner. And I said, okay, Dad, that's really common. I said, when do you go in to have your blood tested? And he goes, what do you mean? And I said, well, they should have you coming in to have your blood tested. And he said they didn't say anything about that. So I said, if they don't call in the next day or two, you need to call them. And it ended up that he did have to call them, and they were very happy that he'd called in because somehow he had fallen through the cracks on that piece. So the takeaway message is, if you have a family member or a patient who's been put on a medication like warfarin, they should be monitored for their bleeding times. Now I'm going to teach you a little test. There are times when we want to manipulate the clotting time of the blood. So typically, the way we'd be manipulating that is making the blood less likely to clot. We want to make that blood slipperier. We said the correct term is slippery instead of thinner. We want to make the blood less likely to clot. So that's going to be patients who have had an embolic. An embolus is a little clot. That's moved. We want to do that in people who've had pulmonary embolus. We want to do it in people like my dad who had atrial fibrillation and they have increased ability to clot. We want to do that in people who have decreased amounts of fibrin degradation product. So if they don't produce their own amounts that break down clots, we want to keep them from forming as many clots. If you've seen a commercial on TV for someone who's having chest pain and it said they talked to their doctor and their doctor told them that if they ever had those symptoms, they should quickly take aspirin. Aspirin makes blood less likely to clot. The prescription drugs that make blood less likely to clot are warfarin, which the brand name is Coumadin, so which one do you think costs more? And in most patients, it makes no difference which one we give them, but in some patients it does. If you change the brands of warfarin, it can make a difference sometimes with patients. So, initially, if we start a patient on warfarin or Coumadin, we're going to monitor them fairly closely for the first few days. Then we're going to monitor them every week, and then eventually we're going to monitor them every month, and they should come to a PT clinic or a PTT clinic, depending on what medication they're on. Here's another medication that makes blood more slippery, heparin. Heparin is an IV drug. Warfarin and Coumadin are oral form. So which one do you think, if we have a patient who's critically ill in the hospital and we want to make their blood less likely to clot, which one do you think we give them? We give them the IV form, heparin. It's going to act more quickly and doesn't have to be absorbed in through the intestine. When they get ready to go home, what do you think we would change them to? So if I saw a patient that was on heparin and now they're changing them to warfarin, I know that they're getting ready to go home. Each of these acts on a different part of that clotting cascade. So warfarin primarily affects the extrinsic pathway. And do you remember the test that attested the bleeding times of the extrinsic pathway? That was the PT test. Heparin primarily affects the intrinsic pathway. And so with heparin, we're going to do a PTT test. Okay, I'm going to go back here for one last thing. My dad was frustrated that every time they did his PT test, it was all over the place. So he had a test done. The bleeding time was too short. So the doctor said, okay, on Monday, Wednesday, Friday, I want you to take a pill, just a whole pill. And on Tuesday, Thursday, Saturday, I want you to take half a pill. So, and I know there's a one day I left out there, but let's say they said 4 days of the week you're going to take a full pill, 3 days of the week you're going to take a half a pill. Come back next week. So he comes back next week and they do a PT test, and they found out that, oh gosh, now your time is too long, which means it takes you way more seconds to stop bleeding. And if we have your time too high, your PT time too high, that would mean that you're more likely to bleed to death. So, we don't want to have it that high, so cut back every day to half a pill. Well, then maybe he would eat a lot of broccoli and he would go back in, and now his numbers are way too low. So do you see how it was important that the patient did their part to look at the things they're taking, like herbal supplements that might affect bleeding times, like the ginkgo biloba or the echinacea. The other thing he had to do was he got frustrated by these PT tests seemed to be all over the board. So look at this thing called INR. It stands for International Normalization Ratio. They finally said, what if we do an average? An average is going to be a more stable number. So there's a formula, and I don't want you to have to remember it, but it makes a more stable number, and it makes one that patients understand better. This is not the ideal interpretation of it, but it's darn close. And it would say that an INR of 1 means it takes you the normal amount of time to stop bleeding that it would a normal healthy patient. An INR of 1.5, like this one, means it takes you 1.5 times longer to stop bleeding than a person who is not on any medications or has a normal bleeding time. So this patient, it takes them 2.7 times longer to stop bleeding compared to a normal patient. And then we had some targets. So they told my dad, we'd like your INR to be about 2 to 2.5. We want you to have enough of that medication that it does take you a little bit longer to stop bleeding than a normal patient. We wanted you not to form clots as easily. We don't want your number to be up to 5 or 6 or 7 because that means you have an increased risk of bleeding. So my dad then needed to have eye surgery. And they didn't want his number at 2.5 for an eye surgery. So he had to come off of his Coumadin, and the day that they did his eye surgery, they took a blood test, and they looked at his PT and INR, and they wanted this to be down to a 1.5 before they would do his eye surgery. And it was, so they were able to do the procedure. Once they got his eye surgery done and the time that the risk of bleeding was low again, they put him back on his medication that made his blood more slippery. So if I've had open heart surgery, they might want my INR time at 1.5 to 2. Those would be kind of the common ones that we would do. Is probably, I haven't really heard of anyone where the doctor said, I want your INR to be 4. I have heard of patients 2.5, 3, maybe a 3.5. Okay, so hopefully those make sense. Now, how can I tell when they're going to do the PT test and when they're going to do the PT? So most of us have 10 fingers. Are you ready? Get those fingers out in front of you. And let's spell out on your fingers H-E-P-A-R-I-N. How many fingers do you have left from that total of 10? You have 3. So if a patient's on heparin, they're going to be monitoring the PTT. If a patient's on heparin, they are looking mainly at the intrinsic pathway, and the way they do that is heparin influences that intrinsic pathway. PTT is the one that focuses on intrinsic pathway of the clotting cascade. If I'm on Coumadin or warfarin, these both have the same amount of numbers. You got your fingers up again. So here's 1, C-O-U-M-A-D-I-N. I've used 8 of my fingers. I have 2 left. And look at this. The PT test is the one that goes with that. So Coumadin plus PT equals 10 letters or 10 fingers. Heparin plus PTT equals 10 letters. So how would I use this clinically then? I have a patient who's on warfarin. What are they coming in for? What clinic do they go to? They say, I go to my ProTime. Well, PT, they're going to a ProTime clinic. And they're going to do INRs. The patients, it's easier for them to understand an INR, and an INR seems to be a more stable number. If I ask my dad, what's your target, he may not know that it's an INR target, but I'll say, is your number supposed to be 2 or 3? And he goes, oh, it's supposed to be 2.5. So he remembers that. So if you know someone who's on Coumadin or warfarin, they have this number. Now, we don't have patients, if they're on aspirin, they're probably looking at something like this, the PT test. But I'm not familiar with, aspirin does such a little, I guess has such little result on this, that we don't normally have patients just taking aspirin who come in very often for a test. But heparin, we're doing a PTT test. Coumadin, we're doing a PT test. This one is only IV, so we're not usually going to be giving it in the home. But do you remember I talked about low molecular weight heparin, and what did I say it was? I didn't say it was a pill. I said it was injection. So heparin usually has to be given either injection or IV. Okay. INR then, we want to make sure that their medication, that they're on the right amount. So the whole purpose of PT, PTT, and INR is let's make sure you're at a therapeutic level. So therapeutic means if the whole reason we put you on this medication was to increase the amount of time it takes you to stop bleeding. We want to increase those clotting time numbers, the length of time. We want you to have it out a certain distance, but we don't want it so bad that you would bleed to death if something happens to you. So one of the stupidest things my dad did, and he knows this, he went out by himself to get some wood. And he had his chainsaw slip, and he cut his leg, and he nearly bled to death. So he did 2 things wrong. He went by himself, and 2, because he was on the blood thinner medication, he was more likely to bleed, and so any kind of trauma, the patient has a higher risk. So an older patient who's on a blood thinner, they may say, we're going to weigh the risks and the benefits. If we have an older person who's very unstable on their feet, and who won't maybe sit in a wheelchair and use it, they're going to say, you know what? The risks are too high. If we put you on a medication that makes you less likely to clot and you fall and hit your head and you have a hemorrhagic stroke because we put you on this blood medication that makes your blood less likely to clot, maybe the risks aren't worth the benefits for that in that patient. So the INR is going to be on a patient who is taking anticoagulant drug to see what their bleeding times are, to see if they're on the right amount of medication. If the INR time is too high, it's up around the 4 range, 5 range, we're going to decrease your medication. If your goal was to keep your INR at 2.5 and your test today said it was 1.5, what are we going to do with your medication? We're going to increase the amount of it. Okay, next thing, we could do an INR on a patient who's not taking any anticoagulant drugs to check for something like a bleeding disorder. And if their INR is high, then we know that there's something that making their blood more slippery. Maybe it's an herbal supplement they're taking. So INR may be a test they do if you come in for surgery to make sure that you are going to have the ability to stop bleeding. Okay, we're back to this picture then. Let's look at this patient and we'll see. D-dimer, we said if it's low, that means they're not forming clots, because D-dimer is a waste product, a thing that's released when there's clots breaking down. INR, they must be on some sort of medication or something, or they have a condition that's making it so that their blood doesn't clot as soon as it normally should. So those kind of go together, don't they? This person has a longer period of time of bleeding, at least with their INRs, and these numbers were pushing those upper limits of normal. Because it's primarily the PTT that's involved, we're going to guess they might be on something like heparin. All right, what is D-dimer? D-dimer is a measure of whether you're forming clots. If you want a fancy thing, I'm going to leave this show for just a minute. So let me get out of the screen, and let me go to our Blackboard website and show you that by clicking on Useful Websites link in your course menu, I have a link to a really helpful lab tests online source. So if you said, I'd really like more information about whatever, you could say, I want to know about D-dimer. And it will say, oh, that wasn't good, huh? That wasn't a good example. How about complete, let's do platelets. We've got platelets, so it can tell me about common questions. So this is a helpful website that would let you find information about different laboratory tests. And you could just punch those in. So if you have a family member who's on a different test, it shows you screening things over here, different types of procedures we might do here, different diseases or conditions that they might be doing tests on, and then some common news things that show up. So I just wanted to show you that helpful website. So I guess you're going to have to trust me on what D-dimer is then. It is really similar to what the degradation product was. So D-dimer is a waste product that's produced when there are clots breaking down. So when should this test be done? If we have someone who we think has blood clots in their leg, so there are some symptoms that can happen. Your leg becomes hot and swollen. If we think someone has pulmonary embolus, I'm going to introduce you to a disease condition called disseminated intravascular coagulation. If we think you have that, if we think you're forming clots, and we measure the D-dimer and it's higher than normal, we know that there must be some clot formation. Now, it's not going to be very helpful if you just had surgery, because can you imagine that if they've done surgery, there were clots that formed in the body and the body should be breaking them down. So clots form, it's a normal process for the body to break them down. If I'm a healthy person, though, I should have small amounts of clots that are forming and breaking down, so there's a normal level for D-dimer. So if I came in off the street and I'm a normal, healthy person and my D-dimer levels are elevated and I'm acting like I have a pulmonary embolus, the elevation of the D-dimer is a helpful piece of information that says, you know what, you're forming clots if you have increased D-dimers. If my leg's all hot and swollen and you're not quite sure if I formed a blood clot in it, but my D-dimer levels are elevated, it tells you helpful information. It says, hey, this is a person that's probably really suspicious for forming and breaking down blood clots. If I've just had surgery, D-dimer is going to be worthless to you because my normals are going to be elevated just because of the surgery. So here's a lab report. Here's the PT that's within its normal range. The INR is within its normal range. The APTT, which is really my PTT test, look at this, it's elevated. So what medication do you think the patient's on to have an elevated PTT? So you can use your fingers. What word, either heparin or Coumadin, do I add to PTT to come up with that right number of fingers? So this patient's on heparin. Heparin makes the blood less likely to clot. And the way I know that it's this one is it affected only the PTT. Now I look at fibrinogen. Does the person have enough fibrinogen to form clots? And I say, wow, that's not good. They have less fibrinogen than they should. And I look at their D-dimer screen, and it should only be up to 500, and it was higher than 1,000. So the only reason to have an increased D-dimer is you've had clots breaking down. So can you imagine, where did the fibrinogen go? Well, it got used up with clots. The body is doing its job, and it's trying to break those down. And we've got the person on a medication to try and keep more clots from forming, and we want the one that acts quickly, the one that goes into IV, heparin. This is a really common laboratory test result for a patient who has a condition called DIC. So clotting factors could influence this. We could measure levels of fibrinogen. We can do a factor II test, the prothrombin, which was the PT test. We can measure clotting factors. We can measure the amount of vitamin K in your blood. And sometimes, even if we've monitored you and watched you, patients will have a complication called DIC, disseminated intravascular coagulation. And I'm going to show you in a video what's happening. And we'll see what we can do to treat it then. So this doesn't have sound, and I can't keep quiet, but I'll try to as much as possible. So look at what the terms mean. So think what the implications of this would be. Where's the clotting happening? So the clotting is happening throughout the bloodstreams in the body. We have clotting at the same time you're bleeding to death because all those clotting factors are getting used up. The fibrinogen is getting used up. So here's normal. Millions of red blood cells, a few white blood cells, platelets, and then clotting factors. But look what's starting to happen to those platelets. So disseminated intravascular coagulation in the vessels. There's clots forming. So think what that would do to blood circulation. So now we've lost blood flow to this area. That would decrease or stop oxygen delivery. Look at all these platelets get used up, and when platelets get used up, fibrinogen gets used up. Sorry about that. The most common, the most common disease we see it associated with is probably sepsis. So let me leave this screen then, and let's go back to our PowerPoint. We had, in the blood vessel, there's coagulation occurring. Because there's coagulation occurring, it eats up the fibrinogen. Remember, it's going to drop platelet counts because platelets are being used up in that clotting process. Fibrinogen's being used up in that clotting process. Clotting factors are being used up. And at the same time there's clotting occurring in the blood vessels, the person starts bleeding from many different sites. Every place there's been a puncture, if you've had a patient that was a trauma patient and they crashed on a motorcycle and they have a lot of road rash, they're going to start bleeding and oozing from every part. So if a nurse or a respiratory therapist or a healthcare provider has a patient who's at high risk, those that had sepsis, trauma, sepsis is an infection in the bloodstream. I probably should define that. I think I did at the beginning, but let me tell it to you again. They could have a transfusion reaction that triggered this. Something triggers this process. And as a complication, there's abnormal clotting in the blood vessel. At the same time, the patient starts to bleed. And the reason they're bleeding is those clotting factors are not going to the right spot. It's like a road detour. The thing that shouldn't stop bleeding, or the thing that should receive blood, is blocking off because of all the clotting process. And that clotting process is using up all of the things that would be needed to stop the bleeding from the road rash or the IV sites or the venous punctures. The management would be to give fresh frozen plasma. Well, do you remember plasma was the liquid part of the blood? And I mentioned when we talked about the liquid part of the blood, it contains the clotting factors. And remember clotting factor 1? The name of it was fibrinogen. Well, the other thing we do is replace platelets, and we'd give those to you in a transfusion. So, I don't want to go to that again. We've already watched it. Let's go to the next slide. And this is pretty graphic, but with DIC, you lose circulation, and you can see this is not going to be saved again. We have permanent necrosis or dead tissue that's happened. This can be seen in meningitis, which is an infection. So we've lost circulation to that part of the body. Some patients do survive DIC with no complications. We have other patients who survive DIC, and they have had to have amputations, and we have other people who die because of the DIC. As you can imagine, those blood clots could block blood flow to kidneys, to vital organs like the liver. And so patients could die from multi-organ failure. All right, a happier topic, blood typing. So I want you to think, some of you know whether you have A positive blood or O negative blood. You've had a blood type, and maybe you've had that done as a procedure at a hospital because you had a surgery. If you've had children, they test the mother's blood type, and they want to know that because of an incompatibility that can occur between the fetus and the mother. So if the mom's Rh positive and the baby's if the mom's Rh negative and the baby's Rh positive, that could cause problems if it's more than the first pregnancy. Usually the first pregnancy doesn't cause problems because the baby's circulation system and the mom's circulation system are totally separated, but at the time of delivery there's some mixing of the mom's blood and the baby's blood. And at that time, if the baby's blood was different than the mom's blood type, it could have the mom's body form some antibodies that could then harm a subsequent fetus. So, if you know what blood type you have, blood typing is fairly quick. Some of you would have done it in high school biology. You might have done it in anatomy and physiology class, and even the most untrained person could probably do blood typing in a fairly quick period of time, like 10 to 15 minutes. You're going to poke your finger, you're going to mix it with a solution, some serum, and you're going to see if you have antibodies. So AB blood contains glutens for A and B. It's going to be anti-A and anti-B antibodies. Type O contains no anti-gluten. So remember, O is the universal donor. AB is the universal recipient of blood. When we do blood typing, we're looking for compatible, means that there would be no clumping. And when we have clumping occurs, if we're doing typing, we can tell that there was some antibodies for that. So there would be clumping that occurs. When we do cross-matching, it's going to look for more than just whether you're O positive or O negative. It's going to look at many other antigen-antibody reactions. And each time you have had blood given to you, it makes the blood cross-matching process take longer. So if you have someone who you know, for some reason they found that their platelet count is frequently low, so they give them platelets and they go in for a transfusion maybe every other month, that person, every time they come back for a cross-match before they give another blood transfusion, it would take longer and longer. It becomes harder and harder to match that person's blood because every time they've been given someone else's blood, there's a few small amounts of antibodies that enter their own bloodstream, and that would trigger their own immune system. So cross-matching takes about 45 minutes to complete. So why would we do both? If cross-matching is the better one, why would we ever do blood typing? Well, if you came in and you were bleeding to death and they have to get blood in you, they could, without doing any tests at all, just start giving you O positive blood, the universal donor O positive. So they start to give it to you, but that's not the best match of blood. The best match of blood would be to find out what is your cross-match type. So they would do a type and a cross-match. They want to know, are you AB? Do you have Rh negative or positive? And then by doing cross-matching, they find the best match of blood for you at that time. So it would be safer if we could do a cross-match. So we do typing to get quick results. We do cross-match to get the best match. So when they roll in the door into the emergency room, we're going to say get a blood type. Start some O-positive blood right now. As soon as that blood type comes back, we're going to do some adjustments. And then when we get that cross-match back, we would switch to the best match of blood for you. Coombs testing. What if we gave you a transfusion and you had a little bit of a reaction to it, but we don't know if you got that rash because of the transfusion or just because you had something else going on with you? Maybe you were allergic to the type of soap that they used on your sheets at the hospital. So it would be real important to know, did you have a transfusion reaction? So when we do that, we have a test called the Coombs test. And the Coombs test, there's one called an indirect Coombs and one called a direct Coombs. If you look, it just says we take the patient's serum, so the liquid part of their blood, and we mix it with donor blood or a sample. We take the direct Coombs, we take the patient's red blood cells, and we mix it with another type of serum, with an so it looks to see, has the red blood cell got something on it that would form the problem. So a direct Coombs, we're going to see it done if you've had or know of someone who has a baby that had jaundice. And they want to know, was there some sort of incompatibility between the mom's blood and the baby's blood? Let's do a direct Coombs. So they're going to take some red blood cells from that baby, and they're going to mix it with the serum and see if there's clumping that occurs. And if it is, then they know there was some sort of antibodies that came from the mom. If we have a mom who is maybe she thought she was pregnant and she miscarried and now she's pregnant again, and they think, wow, the mom has Rh negative. And we really need to know if there was mixing of blood of that fetus that was maybe miscarried. We need to know if she has antibodies that might harm this new fetus. And so we would do the indirect Coombs. So the indirect Coombs is going to be used in pregnant women. It's going to be used maybe before we've done a cross match, but maybe we do an indirect Coombs just to make sure. The direct Coombs is going to be the one that we see if I'm working in the NICU or the nursery. If we have a baby with jaundice or a patient with jaundice, we might be, we talked last time about hemolytic anemia. If you had hemolytic anemia, we might do a direct Coombs to really see if it was because of an antigen-antibody reaction. I would bet most people in the hospital aren't really clear on indirect and direct, so don't do a whole lot of memorization with this. You could find web access pretty quick. But the takeaway message would be the Coombs test is mainly going to be used in patients who've had transfusion problems, in babies who have jaundice or adults who have jaundice, or in suspected hemolytic anemias when we have those rupture of blood cells. What are some of the blood products we use for transfusion? Well, we've talked about some of them. If you had DIC, we'd give you platelets, and we'd give you something called cryoprecipitate. And cryoprecipitate is the medical term for the solution that contains mainly a little bit of plasma and clotting factor. That's cryoprecipitate. It would have that fibrinogen, remember, clotting factor 1. Albumin is a large protein molecule that's in the plasma, and albumin is very expensive. Albumin has some possibility of transfer of diseases, blood-borne diseases, because albumin is known for, I guess, not being able to be screened. It's screened well, but there are some of these products have to be given fresh. They can't be stored. One of those is granulocytes or buffy coat. White blood cells, they can't sit around like red blood cells and be stored, so we have to give you fresh blood. And that fresh blood has not had time to have all the testing done on it. Instead of having family members come in and donate, you guys probably know that patients who have HIV or hepatitis could be totally asymptomatic, but they could pass that disease on through their blood. So instead of just having family members come donate, that's always important to have people donate, but what they will do is take people who are regular donors. They'll take the blood from people who are regular donors. So maybe you're the person who goes in and donates blood every month and a half. And every month and a half they check you for HIV and hepatitis and other things that may be present in your blood. And now they get a need for someone to have those white blood cells that can't be stored, and they say it's a better gamble to take someone who comes in all the time on a regular basis. Maybe we've followed them for years and they've never had a positive blood-borne disease, rather than someone else who's coming in to donate for the first time. So I hope that kind of makes sense. IgG, if you remember the immune globulins, IgE, IgA, IgM, we can filter blood down until we get just the immune globulins. The more we filter or concentrate the products, the more expensive they are. So albumin's expensive, cryoprecipitate's expensive, IgG is very expensive. Plasma, the blood liquids. This is one that would have a high risk of blood-borne disease because that's where those antibodies are. Platelets, not that expensive. I mean, I guess all medical things are expensive, but relatively speaking, packed cells and platelets. I don't see much whole blood given. Whole blood would be the actual solids and the liquids. So whole blood would be white blood cells, red blood cells, platelets. Okay, let's see how we could use this information clinically. If I saw a patient and they got a transfusion of packed cells, what should happen to their hematocrit? So it should go up. At the time we give packed cells, though, we might also give saline. So we might just see that their red blood cell count stays kind of the same if we gave equal amounts of fluid and cells. If we didn't, we'd expect that their hemoglobin would go up. And so if I saw a big bump in hemoglobin rapidly, I would bet that they gave red blood cells. Platelets, we'd give them to maybe patients who have DIC. White blood cells, we give those to patients who have severe infection. IgG immune globulins are part of the antibody system, and so we'd give them in patients who have severe infection. And then cryoprecipitate, really the main diagnosis we're giving that for is either hemophilia or DIC. Albumin is useful in patients who've had burn injuries. Albumin, because it's a large protein molecule, it has a tendency to stay where you put it. So if I put it into the blood vessels, it doesn't leak out very easy. It's going to stay in there, and it's going to have a tendency to hold other fluid in that blood vessel, so it might help with blood pressure issues. So I go in and I donate blood, and they take that blood and could spin it down. And look, we have a solid portion down here and a liquid portion here. Those solids are going to be things like red blood cells, packed red blood cells. We're going to have plasma, the liquid part of it that comes off. And college students are known for going into those plasma donation centers. You know what they do is they take your blood and they separate it and they give you back the red blood cells and they take your plasma. Well, why would they want your plasma? Think of what it's got in it. It's got those expensive things that they're going to sell to people, to hospitals. They're going to sell platelets, or excuse me, they're going to sell fibrinogen, the clotting factors. They're going to make cryoprecipitate out of it. They're going to get albumin out of it. Now we come over here. This is where we're getting things like fresh, frozen plasma. Plasma could be separated down to the clotting factors. This would show kind of the fibrinogen down there. So we can get those. The more we have to filter to separate it, the more expensive the blood product becomes. I gave a transfusion. When we start that blood, we're right there with that patient for the first 10 to 15 minutes. We have them go to the bathroom before we give blood. And the reason we have them do that is we want to know that they started out with clear urine, because if their urine develops any blood in it, we worry that they're having a transfusion reaction. We ask them to tell us if they develop any kind of fever, shortness of breath, if they get a rash at all. So rashes indicate some sort of allergic reaction. If we give the wrong blood, and it does happen throughout the nation, 2 to 3 times a year that somebody gets a transfusion with the wrong type of blood, it can cause fairly instantaneous death. We hope to avoid those things by doing typing and cross-matching, and when we give a transfusion, 2 people at least check that blood to make sure it's the right blood for the right patient. So the thing we worry about is that you'll have a hemolytic reaction. If you have antibodies for the blood you're given, it would break down those red blood cells, and that can loosen up debris that then clogs in your blood vessels and in your major organs. It can lead to shock, and it can lead to death. Okay, longer lecture this time. I will get the quiz posted, and if you have any questions about this lecture or any of the other ones, you're welcome to post those questions on the discussion board or contact me by email or phone. Thanks so much for your attention.